At the Nocturnus, we are careful to ensure that all stories comply with healthcare privacy laws. Details may have been changed to ensure patient confidentiality. All views expressed are those of the person speaking and not their employer.
Hi everyone, I'm Emily Silverman, and this is The Nocturnus, stories from the world of medicine. We've got a couple special episodes for you as we put together season 3 of our podcast. And in this first one, I talk with Dr. Matt McCarthy. He's an infectious disease specialist at the New York Presbyterian Hospital who researches drug-resistant bacteria and fungi. In fact, Matt recently wrote a book about these organisms called Superbugs, The Race to Stop an Epidemic. His book is many things. It's a memoir, it's deeply scientific, it's a history lesson, but it's also just a gripping story of a race against time and biology. First, we have Matt reading an excerpt from his book, where he takes care of a patient with a superbug. Then, he and I talk about the practical, ethical, and emotional aspects of his work and what the future of antibiotics may look like. And before we start, there's something we need to clarify. In our conversation, Matt and I talk about the infamous study of syphilis that started in Tuskegee, Alabama in the 1930s. The subjects of the Tuskegee study were all Black men, and the study was founded on entrenched racist ideas and attitudes. But in this interview, we didn't say explicitly that the subjects were Black. In retrospect, we're clarifying that here, especially for listeners who may not be familiar with Tuskegee and its racist legacy. And with that, here's an excerpt from Superbugs, read by author Matt McCarthy.
It was just after dawn when I felt the buzz on my hip. I broke stride, put down my coffee, and glanced at my pager. I was needed in the emergency room. It was 2014, an unseasonably warm October day, and the text induced a flurry of anxiety and excitement. After 11 years of training, I had accepted a position as a staff physician at New York Presbyterian Hospital, a tertiary care center on the Upper East Side of Manhattan. And a patient had just arrived with a perplexing infection, one that had stumped the team in the ER. A moment later, I was standing before a group of medical students and residents and my new patient. The young man writhing on the stretcher was an African-American mechanic from Queens named Jackson, with dark green eyes and a small Maltese cross tattooed onto his neck. He had been shot. My patient, I discovered, was infected with a nimble and aggressive new bacterium that was resistant to every antibiotic at my disposal, except for one, colistin. I had used the drug only a few times in my career and never with good results because it was so outrageously toxic. Colistin might kill bacteria, but it destroyed kidneys and other internal organs in the process, leaving many of my patients with just two options, dialysis or death. I crouched to meet Jackson's eyes and carefully considered my words. "You have an infection," I said. "A severe infection." The man's gaze darted from me to the men and women standing in a horseshoe behind me. "How severe?" He took in a small breath of air and held it, waiting for me to say something. It felt like an hourglass had been flipped. Suddenly, the tiny room was very hot. I took off my white coat and rolled up my sleeves. "Quite severe." His eyebrows raised, and I reflexively extended my arm to hold his hand, but caught myself. I wasn't supposed to touch this patient without protection. I pivoted back to my team. "Everybody out, now." I pointed toward the door. He grasped his thigh, inches above where the bullet had entered. Beneath his fingertips, bacteria were rapidly multiplying, devouring muscle and bone. "Am I going to lose it?" he asked. "The leg?" In truth, I wasn't sure. Only colistin had a chance of destroying the infection, but there were no guarantees. The last person I prescribed it to died 12 hours after she received it. The one before that died while receiving it. "I don't think so," I said, as confidently as I could. I squeezed his sweaty hand and tried to imagine how I would summarize the nuances of the case for his wife and children. They would need to take special precautions just to be in the same room with him. "We're going to get you through this," I said, as his eyes began to water. "We will." I left the room, removed my gown and gloves, and addressed my team. "Start colistin," I said. One of the residents frowned as she scurried to a computer to put in the order. Then we vigorously washed our hands and moved on to the next patient.
Thank you, Matt, so much for reading that excerpt from this book, which just feels like it opens like a thriller to me. I don't know if that's what you were going for, but I can just feel the suspense in the room there.
Well, I wanted to give people a sense of what it is that we're encountering every day in the emergency room, and I talk about these things with my parents and my family and all my friends who aren't in medicine and realize they really have no idea. I chose a patient who had colistin as the only option because, that's an antibiotic that fell out of favor years ago because it was so toxic, and here we are reaching for it. And if you go on social media now, you'll see infectious disease specialists who are saying, I think I have to use colistin here. Is this okay? And that's crazy. But that's the crisis that we are confronting now in public health.
While I am an internist, I'm not an infectious disease specialist. And I remember when I was reading your book, I thought to myself, at the general, we have a lot of infections, but most of the time we can treat them with antibiotics. And then, of course, I'm halfway through your book and I'm at work and the patient comes in who has the meropenem-resistant urinary tract infection. And for the audience, meropenem is an antibiotic that, is incredibly powerful and treats almost anything. And so for a UTI, a urinary tract infection, for the E. coli, the bacteria that causes that, not to respond to meropenem is a really big deal. And that's when I thought, oh, wow, it's so funny that this is happening right as I'm reading Matt's book. And so what I wanted to ask you, for lay people, but also for doctors who aren't infectious disease specialists like myself, the title of your book is Superbugs. Could you tell us, what is a superbug? How do you think about it? How do you define it?
Some people would say that superbugs are just drug-resistant bacteria. I take a far more broad view of it, and I would say that it also includes drug-resistant fungi and viruses and parasites. In fact, the World Health Organization just came out and said that superbugs are going to be a bigger killer than heart disease and cancer by 2050, and that 10 million people will die every single year from these drug-resistant infections. I got an email recently from a professor at Cleveland Clinic who said, you really shouldn't use the term superbugs. You should actually use the term difficult to treat infections. And I said, well, that's not much of a book title. And it's also not accurate. I saw a patient this morning who had a urinary tract infection with an E. coli that was resistant to 8 different antibiotics, but it was susceptible to Levaquin, which means I easily treated it, even though it was this superbug. And so one of the challenges I had in writing this book was conveying the nuances and the complexities of drug-resistant microbes and explaining why this is such a problem and how we got here and what we can do about it.
How did we get here? How did we get to a place where these common bacteria, pneumonias and UTIs, suddenly are no longer responding to our antibiotics?
Yeah, I was doing a book talk the other day and a guy raised his hand and said, you know how locusts were cast upon the earth as a judgment on the behavior of humanity? Have superbugs been cast upon us as a judgment of our behavior?
Wow.
And I said, well, that sounded like a wacky question at first, but in some ways, we did bring this on ourselves. The first commercially available antibiotic was penicillin in the mid-1940s, and that ushered in what we call the golden era of antibiotic development, the 1950s. And there were all of these life-saving drugs that were coming out every few months, and the life expectancy for humans ballooned dramatically. But then something happened, which is that a number of prominent scientists came out and said, we got this infectious disease issue kicked. We should start focusing on heart disease and cancer and all these other problems. And the big pharmaceutical companies shifted their focus to things that were more lucrative. And that happened at a time when the superbugs were just starting to appear and started mutating and evolving. And now the way that we're creating these superbugs is that we're using the precious treasure trove of antibiotics that we have in places we shouldn't. We're using syphilis drugs and tuberculosis drugs in our orange groves. We are using one of our powerful antifungal drugs in tulip gardens. And then, of course, doctors are inappropriately prescribing antibiotics and patients aren't taking them as directed. One of the new areas that we're looking into now is that the dentists are often giving out antibiotics inappropriately. So a lot of research going on in terms of how we can do a better job using the treasure trove that we have.
And you talk about how one of the best places to find new antibiotics is actually right under our feet. It's in the soil. So can you talk a little bit about that?
Yeah, isn't that cool? That there is beneath our feet in the soil, there is what I call it a subterranean warfare, where all of these microbes are busy creating little chemicals that they secrete out, trying to kill everything around them. It's like this Darwinian survival of the fittest. And those chemicals that they make, if we can pluck those out and isolate them, those can become antibiotics. The challenge, of course, is finding them. And we're now starting to use artificial intelligence and big data and chemical sequencing to try to figure out where to look. Where do we get that needle in the haystack? Because once you find that chemical, it typically takes at least 10 years of testing and at least $1 billion to bring it from the soil to the bedside, because the net present value of an antibiotic is negative $50 million, which means when a company invests in a new drug, a new antibiotic, they typically lose $50 million. So we're trying to figure out how do we entice big pharma to stick with us and to keep making these drugs. And that's proving to be a very challenging and one of actually the most important issues in public health is who is going to make the next generation of antibiotics.
I do want to talk a little bit about, the people who are involved in developing the new antibiotics. And one of them is this character, Tom Walsh, who happens to be your mentor. And he recurs as a character throughout the story. And he is just so compelling as a character. Tell us about Tom Walsh and what it's like to work with him.
I met Tom when I was a resident at Columbia, and I was interviewing for ID fellowship. And he just kind of one of those people that you won't forget. And he's one of these guys who is an old school doctor, the kind who used to stay till midnight, show up at 5 a.m. the next day. And he is trained in internal medicine and pediatrics, in oncology, infectious diseases, surgical path. And he's a world-class medical mycologist and one of the experts in fungal infections. And so, he knows more in his pinky than I'll ever know.
And I love how in the book we see how Tom is, in a sense, grooming you to replace him. And you talk a lot about your similarities, but also about your differences. And one of the ways that this comes out is in your music choices. And that Tom really loves to listen to classical music, but you talk about how you like to listen to the Eagles, and you actually take this a step further and talk about this obscure musician in the Eagles, Randy Meisner, and how you just feel this kinship to Randy, and you sort of use that as a way to frame your comparing yourself to Tom or not comparing yourself to Tom. And I just thought that was such a wonderful, personal, real detail. And I was wondering if you could talk to us a little bit about Randy Meisner and what is it that makes you feel so connected to Randy?
I'm so glad you asked that question. I've talked about this book quite a bit, and no one has asked me about poor Randy Meisner. I was kind of, following this guy's life, and he played back up to, these musical geniuses. And then he finally got to write a song that he was the lead vocal on. And I thought that was so cool that, that he was the Ringo of the band kind of, and that it was such a good song that they would play it for the encore. But he had stage fright and he got nervous. And there was a night where he refused to go on because he was crippled by insecurity. And he was surrounded by these people who were so talented, and he just didn't feel comfortable doing it. And I thought, gee whiz, I'm surrounded by such brilliant minds in the hospital. I kind of got drawn into this comparison of, not necessarily feeling like you're up to the task, even when the people around you are saying, no, you can do it. And it became a very powerful thing for me. And what was great was by the end of by the end of the book, Tom actually became an Eagles fan, and I'd go into his room and he'd be telling me how many great songs they have. But ironically, many of the people I am very close to do not share that opinion of the Eagles. So yes, it was a random divergence in a book otherwise about microbes. The great thing about writing for doctors is that they can sniff out BS and they can tell when something's not true. And it's really a challenge, I think, to reveal yourself in a way that's true to you, but that's also true to the people who work with you every day.
Mm-hmm. And that ethos, I think, persists throughout the book because it's about a clinical trial, but it stays very personal and very character-driven. And you talk about how as you're enrolling individuals in the trial, you're actually going into the room and meeting them face-to-face and consenting them one by one, and how you're doing that with this legacy behind you of sort of a sordid history, actually, of human experimentation, and how that is very much on your mind as you're doing this. And so first, I'd love if you could just share with the audience a little bit about the history of human experimentation and clinical trials and that background there.
Sure. Well, the unexpected nemesis in this book for me was the IRB, the Institutional Review Board, that basically allows a clinical trial to happen or can shut it down. And they tortured me. And what I wanted to do was to
as they do most people.
Yes. And I wanted to provide the historical backdrop to explain why they were torturing me. And the reason for that is that doctors have been have had appalling ethical lapses for generations. And we used to be able to police ourselves and decide what was an ethically appropriate study. And that turned out to be problematic because we weren't very good at it. And, I start with the Nazi doctors. That's a very obvious, egregious example. But then I also talk about Tuskegee. And I think a lot of people are familiar with the broad strokes of what happened with the syphilis study, but they don't recognize some of the nuances about how this was not a secret study. This was discussed openly at medical conferences for years. And there were, people from the federal government, the NIH, would consistently say, this is not going to even provide any useful new knowledge, but we'll sign off on it to allow it to continue. And that's crazy. That looking back on it with through the lens of history, we say, how did we get to this point? But that's why we have these IRBs, and that's why they are so meticulous when they go through a protocol from someone like me. I can't just go onto the Goop website and pick off some random new treatment and walk in and say, I'm going to start treating people with this thing because Gwyneth Paltrow or Dr. Oz says it sounds like it's really promising. And that's important. And I found out just how important it was when I started consenting patients. And, you could be talking to somebody who has an 8th grade education who is saying, I don't really know what to make of this, but it's important to me that the hospital has signed off on this. And that brought up a really tricky ethical issue, which is that I found I'm very good at getting consent, but I didn't always know if it was informed consent. And one of the things I would do is bring junior investigators with me to say, we would go and consent a patient for a trial, and I would say, do you think this patient understands what they're getting themselves into? And that sort of lended itself to my other research career, which is in medical ethics. And I'm fascinated by how doctors make ethical decisions, and I'm on the ethics committee at Cornell, and why it is that doctors don't always make ethical decisions. And I turn the lens on myself as well, because this is a very, it's like, it's a high wire act to pull off a clinical trial. And the thing I was most interested in was those human interactions where I was talking to somebody who was trying to figure out if they should enroll. And one guy stopped me and said, I just have one question. And he was a lawyer. He had spent a career reviewing documents, and he had the consent form in his lap. And he said, I just want to know, would you give this drug to your own mother? And that kind of caught me when I froze. And I said, yeah. And he said, okay, that's all I need to know, and I'll sign off on it. And those kind of moments you can never expect until you actually are running a clinical trial. But it was a fascinating experience for me.
You mentioned Tuskegee earlier, and I don't know that all of our listeners are familiar with what happened there. Can you summarize for us what happened in Tuskegee?
Sure. So in Alabama in the South, there were a large percentage of sharecroppers who had syphilis. And initially, the treatment for syphilis was not very good. It was mercury-based injections and arsenic, and relapses were common. And what there was this plan was to say, well, why don't we observe this cohort of sharecroppers and see what happens to them when having syphilis? What's the natural course of the disease? But shortly after the study began, penicillin became available, and penicillin was a cure. We're still using it today for syphilis. And it's not that the sharecroppers were denied treatment. It was just never offered. Nobody bothered to tell them that there was this new cure. And so they lived their lives not knowing that they had this contagious disease that could cause birth defects, that was sexually transmitted. They weren't given any of the proper information. And they largely remained very loyal to the study. They felt like they were getting, free checkups and medical care. Meanwhile, the doctors behind the scenes, who were, paid for by our tax dollars, were figuring out ways to manipulate these sharecroppers and to get them to, consent to a lumbar puncture by not telling them how much it would hurt or what the side effects could be. And this went on for decades. And it was really this, state-sponsored terrorism, where even when the sharecroppers died, they would donate their body to the government to look at, the syphilis in the aorta or in the brain or the various aspects of their body. And it wasn't until a whistleblower in the early 1970s came out and said, "Do you guys know what's going on with this syphilis study?" And there was immediate outrage. And there were these congressional hearings, and it really was the first time that the public became interested in the ethics of research, and especially government-funded research. And every medical student and doctor henceforth is now has to learn about Tuskegee and must learn about how easily these doctors felt that they could manipulate people for the betterment of science without thinking about them as human beings. And I'd heard about Tuskegee, but it wasn't until I started reading the books about it that I couldn't believe what I was seeing. And especially to look at the conferences where this stuff was discussed routinely without any care for how it was affecting the lives of the people who were, having children with birth defects without even offering them treatment. So I thought that was an important historical grounding for, how we got to this point.
I want to pivot a little bit to this moment where you finally move on to the portion of your trial where you're able to give Dalba, this drug that you've been looking at. And it's a drug that's given, I believe, as an IV infusion, correct? And so it's trickling in through the IV into the vein of this man who's the first person at York Presbyterian ever to receive this drug. And you're there in the room sitting at the bedside as it goes into his body, and you're just hyper vigilant, like watching every twitch in his face, ready to spring into action should he have some kind of adverse reaction. And it was just such a high pressure moment. I was wondering if you could bring us into that moment. What was it like to watch somebody getting this new antibiotic for the first time?
Well, I was as nervous as anyone could have possibly been in that moment. And I think what's interesting about it is I had just finished telling this guy that I would have given the drug to my own mother and that I was confident it was going to work. But as it started dripping in, I got a little bit nervous. And when he took a deep breath, I inched towards him. And when he closed his eyes, I inched a step further. And with every, subtle facial twitch, I was living and dying in that moment. The other added nerve-wracking part of it was that this was one of these drugs that you take it and then you go home. So we were, this was the last time I was going to lay eyes on him. So he had this Superbug. He was getting a brand new drug. And then we were going to say, okay, see you in 2 weeks. And so I was very anxious about how that was going to work. And fortunately, it worked beautifully.
I would love to hear about the status of Dalba now and just your vision for the future. How can we continue on this path of preventing the superbug infections and developing the antibiotics and making sure all the incentives are in place? And what do you envision as a path for the future?
Yeah, well, dalbavancin is instructive, I think, as a case study because it's a drug that costs $4,000 for a single dose. And my hospital, which is one of the biggest in the country, initially refused to carry it. And they said, Vanc works just fine. Vancomycin costs $40 a dose, treats the same condition. There's no way we're going to pay a ransom. And I designed a study where I convinced the company that makes the drug to give me some of it for free. And I said, what if we could design a study where we decrease the length of stay so dramatically that this drug pays for itself? And so that's what I chose to write about. And what was interesting was that when I finished the study, I presented it to the formulary committee at my hospital, and they unanimously approved it. And so now we're rolling it out at our hospital and, going to be rolling it out all over the country. But it brings to light, I think, a really important issue, which is that the pharmaceutical industry is losing interest in making new antibiotics because it's so expensive to make one. And when they get the drug approved, they want to recoup their investment. So they're charging thousands and thousands of dollars a dose for these drugs. And the hospitals are saying, no, thank you. And I thought that was fascinating that, I work at York Presbyterian, one of the best hospitals in the country, and we don't carry many of the newest antibiotics for the simple reason that they're too expensive. And so we've got to figure out a path forward to make the drugs profitable for the pharmaceutical industry, but also affordable for doctors and patients to actually use them. And so there's a host of proposals on the table to make this happen. And the other option is to say that pharmaceuticals don't want to make these antibiotics. Well, good riddance. We should nationalize the production of these drugs, and that antibiotics should be viewed as a public good, like electricity or water, and the federal government should be responsible for making them. And we should disentangle profits from the equation, and that these are things that we should just share and jointly invest in and jointly share. And that, may be something that we hear more about in the coming years.
Thank you so much, Matt, for that beautiful explanation of the future of antibiotic therapy. Is there anything else that you want to share with us? Anything else that you haven't said that you would like for us to hear about superbugs?
One thing that I haven't talked about is I talked a lot about the ethical challenges associated with clinical trials, but I haven't talked about the ethical challenges of talking about superbugs. And for me, this happened a few months ago in April when a multi-drug resistant fungus called Candida auris popped up on the front page of the New York Times. And I was quoted in the article because I'm one of the handful of doctors who have treated patients with this type of infection. And it's one of these pesky pathogens that's resistant often to all of the treatments we have. And it was discovered in the ear of a woman in Japan in 2008 and quickly spread around the world. And after that article appeared in the Times, Good Morning America asked me to come on and talk about it. And my hospital said, we have declined your invitation. And I said, can you do that? And they said, we already did. And I discovered that my hospital was not particularly enthusiastic about me talking about superbugs. And the reason is that they're concerned that we would get labeled as a haven for these things and that people would avoid seeking medical care because they thought they might pick up one of these pathogens. And, that couldn't be further from the truth. All the patients who I treated, we cured. And so I ended up writing an op-ed in the Times, in the New York Times, about this, that the best hospitals in the country are going to see more superbugs, and you shouldn't avoid them. They have the most powerful diagnostics. They have the best antibiotics, the experts who know how to treat them. They take the referrals from hospitals that can't handle these complicated cases. And all of that swirled around me right as this book was being released. And it made me realize how much more work we have to do to convey to the lay public exactly what we're seeing and doing in the hospital to cure patients, to protect them, to keep people safe, and also to discover, the next crop of antibiotics to save all of our lives. That's going to be the mission that I'm on, is to figure out how we can talk about this stuff responsibly and not be alarmist, but to draw attention to what is undoubtedly the most important public health issue of our lifetime.
Wow, yeah, that's a really interesting dilemma is, if you publicize it too much, are people afraid to come into the hospital, and how do you balance that as well? So it's a huge challenge, but I just want to say thank you, Matt, for all of the amazing work that you're doing as a physician and as a researcher. And thank you so much for coming on to The Nocturnist to share your story and to talk about superbugs. It's been a pleasure to chat.
Oh, thanks so much for having me. This was a lot of fun.
That was Dr. Matt McCarthy. I highly recommend checking out his book, Superbugs: The Race to Stop an Epidemic. Please let us know what you thought of this special episode. We're really looking forward to next year when we can bring you Season 3 of our show in its full force. If you're interested in supporting us as we produce Season 3, I invite you to visit our website at www.thenocturnist.com and learn more about options for donation and sponsorship. We'd love to welcome you into our family. This episode of The Nocturnist was guest produced by Diantha Parker with editing support from assistant producer Kirk Clockey. I also want to thank our executive producer Allie Block, head of story development Adelaide Papazolo, sound engineer Alberto Hernandez, our podcast intern Chloe Lassard, and our fundraising lead Cecilia Peterson. I'm your host, Emily Silverman, and we are The Nocturnists. Be well.